Yes, sir, we are live now.
Okay, sir. A very good evening to all the eminent doctors. Thank you so much for joining us for today's webinar. The topic of webinar is the dosage reduction strategy in rabies management, role of novel vaccine. With this, it is my honor to introduce you to the speaker of today's webinar, Dr. Avik Basu, MD physician, graduate and postgraduate from Calcutta Medical College. Complete certified course in evidence-based diabetes management from PHFI under mentorship of Dr. Anirban Majumdar. He is certified for the fundamental critical care support by the Society of Critical Care Medicines, USA, pursuing MRCP UK currently. Complete integrated diabetes and endocrinology course under the University of Newcastle, Australia. Also pursuing certified course in Oviside Prevention and Management under PHFI. He is associate member of Royal College of Physicians, Edinburgh. He is an international affiliated member of Royal College of General Practitioners, London. He is reviewer in endocrinology and metabolism session of American Physiology Society. He is reviewer is request Dr. Avik Babu to initiated the talk of Travis.
Thank you, Mr. Ghosh. So without
Thank you,
taking,
sir.
without delaying anymore, let me just welcome the learned audience. Obviously, I can see a few known names in the audience list. Two of them whom I know personally. So welcome everyone. Today, the topic has already been explained. That's the novel 3-dose G protein vaccine, ultimate key for compliance. That is the new anti-rabies vaccine that has been launched by Zavis Karila. Since our MBBS days, we have been learning about rabies, dog bite, and also during our classes of community medicine, we would used to read about the egg vaccines, the cell culture vaccines, the updated regimens. Used to have these used to be the favorite questions during our viva or the theory examinations regarding the dosage on the pre-exposure, post-exposure, re-exposure prophylaxis. So this is basically just an extension from the already existing armamentarium of anti-rabies vaccination. We have the novel 3-dose G protein vaccine, so recombinant vaccine. So let's just slide across the slides today. So rabies, it's a public health challenge in India. Globally, 59,000 human deaths annually from rabies, and highest in India. India had 20,000 human deaths a year from rabies, accounting for about 60% of the rabies deaths in Asia and 35% globally. 91% deaths in India occurred in rural areas. However, to be very frank, these days, probably the incidence of rabies has come down considerably. I remember during our training days, during internship period in the Department of Community Medicine, we got posted for about 15 days in the infectious disease, Belghata, IT hospital. And there I saw just one rabies patient. Remember, till today, I remember that scene, that agony that the patient was going through. That was just one case that I had seen visually, and I vividly remember that nightmare kind of a thing the patient definitely undergoes. It's absolutely fatal disease, 100% fatality. So every 9 minutes, a person dies from rabies. So the current management, obviously, we know that there are 3 categories of rabies. The first category is benign one, then comes the category 2 and the category 3. And the management is, first of all, the local wound clearing. So wound treatment, the first aid, we used to clean the wounds for about 15 minutes with soap water. That used to be the, probably the first line in the textbook of community medicine by Park, that we need to wash the wound with soap water for 15 minutes. No use of any, carbolic acid or any sort of a thing that is going to further aggravate that tissue damage. You can use antiseptics, yes, but I think washing with the soap water for 15 minutes is enough. The next line, obviously, we need a tetanus vaccination. That's the most important thing that we can't miss in any of the categories of rabies. Then comes active immunization that plays an important role in both category 2 and category 3 rabies, and passive immunization typically conserved for the category 3 rabies. This was the 5-dose or Essence intramuscular regimen. We know there are two forms of vaccinations, the intradermal and the intramuscular. And the intradermal dosage is 1/5 of the intramuscular dosage. The intradermal dosage that we basically used to follow till date was the updated Thai Red Cross regimen, that is 03728 day. And the intramuscular regimen was the 0371420. So there were 5 days in the intramuscular schedule and 4 days in the intradermal schedule. That was a 2-side regimen for intradermal and 1 side for the intramuscular. So this was till date, even what I used to follow as well. Probably every single physician or anyone who is an expert in the field of community medicine used to follow, and that used to be the textbook recommendation as well. Now, the current challenges, what are the challenges basically that we face with post-exposure prophylaxis? The first of all, obviously, is compliance. Because of the 037, probably the first 3 dates seem to be quite close to each other. The last one is the most likely to be missed, the 28th day. So that's non-compliance. That's the most important challenge that we face as far as rabies vaccination is concerned. And the current rabies vaccines, they're cell culture vaccines, the neurotropic vaccines, the XL vaccines, they're long gone because of their, array of side effects. We have the cell culture vaccines, the cell culture vaccines, all the human cell culture vaccines. The inactivated vaccines are more than 50 years old technology. So there's inconsistency in the potency of the vaccines. There is issue with the stability. Availability, obviously, there is a very short supply, because a lot of cases I've seen that patients, ring up a number of times that Dr. Abu, pachina dokane a vaccine. Literally, that's the major challenge that they face. Maybe in some hospital setups, it's more freely available rather than in the pharmacies. So that's an important, point that needs to be mentioned, the short supply. And obviously adverse effects. Adverse effects, however, we don't see much these days when the cell culture vaccines have come. The major issue is obviously the non-compliance, mostly with the last date of the vaccine schedule. So the compliance issues, an individual is said to be compliant, obviously, who has received the full course of the anti-rabies vaccine with scheduled dose on the recommended days, be it an intradermal schedule or be it an intramuscular schedule. Delayed compliant means they have completed the schedule, maybe of five sets of vaccinations or 4 sets of vaccination, but that obviously not within the prescribed dates, but within 60 days. Definitely they have deviated from the scheduled regimen, but they have completed the whole course, but that's a delayed compliance. And dropouts are non-compliant. That means who have taken at least 1 dose of anti-rabies vaccine after the animal bite, but not completed all the scheduled doses. So these are the 3 categories of compliance and non-compliance. So non-compliance to 5-dose cause of death. So this has been a study, basically a comparative analysis of the different, patterns of the post-exposure prophylaxis. We can see that the 3 cases being mentioned. The first one was 3 doses, and there was no rabies immunoglobulin administered. The second one, 3 doses with no rabies immunoglobulin. Third one, 3 doses, no rabies immunoglobulin. In the second one, we can see that the vaccine type was unknown. In the first one, it was a Rabipur vaccine, and the third one, once again, the vaccine type was unknown. You can see the chronology of the events. That was all these 3 categories were category 3 bites. So basically, they required both a vaccine and an immunoglobulin. And we say that the anti-rabies vaccine should be taken not after 24 hours of the bite, and immunoglobulin not after a week of bite. So diagnosis considered was all these 3 cases: rabies encephalitis, the most dreaded complication, the most fatal complication, we can say. Outcome, in the first case, the patient hospital survival of just 16 days, died after 1 day due to LAMA. The second one, LAMA on the same day of admission and death followed after 2 days. And the third one, expired on the day 2 of admission. So there are different, reasons. First of all, non-compliance, because the patient has left, so there was no trace, no follow whether the individual has taken the vaccine or not. And obviously, maybe the individual has delayed the starting initiation of the vaccination. So there are different causes as to the fatality of rabies. Otherwise, if the regimen is strictly followed, if the advice is strictly followed, then we can ward off the fatality of rabies. The individual is most unlikely to land up in bed and in deathbed. The reason of deaths may be due to lack of administration of rabies immunoglobulin or poor compliance to vaccination, because none of these three patients, even when bitten by a dog under category 3 dog bite, were not administered with the rabies immunoglobulin. So there was an article that's compliance to post-exposure prophylaxis among animal bite patients, a hospital-based epidemiological study conducted by the Department of Community Medicine in New Delhi, India, and Safdarjung Hospital, New Delhi. About 360 animal bite patients were included in the survey, and a pre-designed, pre-tested structured questionnaire was administered by the interview technique, and it was found that 53% were non-compliant to the full course of anti-rabies vaccine. That was quite a significant number. More than half of the population were not compliant to the entire course of anti-rabies vaccination. Compliance to anti-rabies vaccination post-exposure prophylaxis. So once again, at Municipal Corporation Hospitals, Bangalore, there were 215 animal bite patients registered. And what we can see is that the compliance to the vaccine was gradually reducing as the dates were increasing. So we can see almost on the first day, day 0, the compliance was 100%, excellent. Day 3, 88%, not that bad. Day 7, 85%, still not that bad. But from 14th day, 28th day, it fell sharply. So the compliance rate for intramuscular rabies vaccination was overall 60%, obviously fell considerably on the last 2 days. So constraints for compliance to complete the course of anti-rabies vaccine. First of all, there is loss of wages. That's accounts for 47%, the majority. Then it's forgotten dates. I think that should always be the first reason for non-compliance, followed by cost incurred, distance of the hospital interfering with the school timing. However, in our day-to-day practice, we meet more of the forgotten dates category as the major issue for non-compliance to anti-rabies vaccine. The major constraint for non-compliance to anti-rabies vaccine was in this study loss of wages. Practically, it's more of the forgotten dates. Now, the evolution of the vaccines, we know nervous tissue vaccines, live attenuated and the inactivated vaccines have long been, forsaken. We basically use these cell culture vaccines these days. Mostly the 5 injections, that is for the intramuscular schedule, and 4 injections for the intradermal schedule. So non-compliance led to evolution in the treatment regime from 31 dose to 5 dose and still on. Now meeting the unmet medical need, introducing a novel vaccine with simple and shorter regimen. However, I would like to mention that there was a shortened regimen actually. The Red Cross, the updated third Red Cross regimen, they said 5-day vaccination with the intramuscular injection and the 4-day vaccination with the intradermal. However, they reduced it to a 3-day vaccination. That was a more short regimen, made easy for the patients. However, that's obviously a questionable thing if you are reducing the same variety or the same vaccine manufacturing technique and everything remains the same. That particular vaccine, the regimen we are reducing just for the sake of patients' accessibility or ease of administration. Are we not compromising with the quality of care or prevention that is being given? So therein lies a big question. That is why Cadila has come up with a novel vaccine that has got a 3-day regimen. There was no previous extended regimen that has been cut down, but it is basically a 3-day vaccination regimen with a new technique or technology. That is, they call the rabies G protein vaccine, recombinant one. So the novel 3-dose recombinant rabies G protein vaccine, first protein subunit vaccine prepared by the virus-like protein platform technology, the first vaccine with 3-dose intramuscular regimen, and days are 0, 3, 7. We can expect that the compliance is going to be the best because the entire regimen is going to be completed not more than a week. and better compliance due to easy of to flow regimen and less visits. So it's more affordable, accessible, easy to remember by the patient. So convenience, ready to use, no reconstitution needed. So these are the benefits. Just 3 doses in 7 days. Now, the VLP technology of the virus-like protein technology that is used for preparation of this particular vaccine by Cadena. There's a native virus. Finally, they form the vaccine-like protein of the vaccines. So G protein is difficult to stabilize. And the G protein isolation using this VLP technology purified and stabilized by Cadena Pharmaceuticals Limited. Virus-like particles, a protein complexes that exist in nanoparticles. So what basically they are doing is they are preserving the infectivity or the antigenicity or the immunogenicity of the virus, but destroying the pathogenicity. The VLPs are similar to native virus particles, but that do not contain the viral genome. So the pathogenicity is being abolished. Only the immunogenicity is being preserved so that the individual's body can surmount the cellular and the humoral responses. They cannot replicate, but can mimic the viral antigenicity without being pathogenic. That has been the modern technique of treatment in a number of diseases. We use viral vectors also, we know, basically to preserve the immunogenicity, but to abolish the pathogenicity. Similar technology, they are capable of inducing a strong humoral and cellular immune response. Once again, another clinical trial published in the Human Vaccine Immunotherapy Journal, safety and immunogenicity of a novel 3-dose recombinant nanoparticle rabies G protein vaccine administered as simulated post-exposure immunization, a randomized comparator controlled multicenter phase 3 clinical study. So what do we see here? To evaluate the immunogenicity and safety of the rabies G protein vaccine administered as simulated post-exposure immunization in healthy volunteers. So there were 800 subjects that were included in the trial. And there were the two trials, that is the standardized cell culture vaccine Rabipur, and there we have the novel vaccine Travis. So that was a 037 days regimen for the Travis, and for Rabipur 037 1428. That is the intravascular schedule. And what do we find? Here we can see the efficacy is not at all non-inferior. It's very much comparable to the reference vaccine, that is a Rabipur. The results were consistent across different age groups and genders. Observed difference 1.52% with a pre-specified margin of -4. So non-inferiority for seroprotection, primary endpoint, day 14 and 42 were met with Travis. And safety, here we can see that the study shows their adverse effects percentage, local adverse effects, systemic adverse effects were all much less significant with the Travis. So both for the efficacy and the safety criteria, they have met. So conclusion is novel 3-dose vaccine was non-inferior reference vaccine, less adverse effects compared to the reference vaccine. Novel 3-dose was found to be safe and immunogenic and was comparable to the 5 doses of WHO pre-qualified vaccine. This is more of a page dedicated to Cadila by Cadila. There have been awarded as the Pharma Innovation of the Year with Economic Times and the Golden Globe Tigers Award Malaysia for the Innovative Product of the Year. So literally we have another second-line vaccine. We used to have the cell culture vaccines. Now we have the recombinant G protein rabies vaccine with a much more easier regimen to follow for the patients and easy to be administered. It's an intramuscular regimen, not an intradermal one. So one side, 037 days. And it can be used in both category 2 and category 3. But obviously, we should never forget administering the immunoglobulin whenever it comes to category 3 rabies vaccine. So thank you, everybody. Hope this short session has been a crisp one. Now over to the audience and over to the host.
Thank you so much, Dr. Dr. Avik Basu, for the informative talk. We truly appreciate your efforts. Thank you, sir. Thank you very much.
So I'm leaving, huh? আমি তাহলে লগ আউট করছি।
Okay.
Okay.
Okay, sir.